It's a pleasure really to be with you and to spend this time with you. As Dr. Arania said, the lecture is going to be recorded. It is recorded, and it will be available for you for a month after today. I have nothing to declare. I just want to say that feel free to take a screenshot at any time. And even in the future, if you think that some of the pictures you see you will be interested in for your lectures or your teaching, please send me a note, an email. I will be very happy to send you any picture of any tumor or anything that you like that you can use for your teaching. I want to start by an introduction of embryology and a little bit over review of the classification. I will spend the first half of the talk for frozen section and intraoperative consultation, and then the second half I will just give some update on I want to start by the surgical pathology test cycle that we all know. You start, the clinician sees the patient, take them to the OR, take a specimen, sends it to the lab, you get a biopsy, and you look at the slide, and you release a report to the clinician, and the clinician gives the treatment to the patient. So this is what we call the test cycle in surgical pathology. By the way, the person you see in the right lower corner here is Dr. Juan Rosai. Of course, he passed away now, but when he was around, he was here. He was sitting in this office. This is the office of Juan Rosai when he was at the University of Minnesota. I'd just like to point out this great man. The first part of the cycle here, this is what we call the pre-analytic phase of the cycle. The pre-analytic phase means anything that happens before the specimen gets to the lab. Once the specimen gets to the lab, we call that the analytic phase of the test cycle. What happens in the lab in terms of preparing the slides and looking at the slides. What happens after that is called the post-analytic phase. This is from the time you release your report to the time the patient gets the treatment. Everybody knows that pre-analytic, analytic, and post-analytic. The reason I'm going over this with you now is to highlight the fact that ovarian pathology is one of the areas where we didn't really make much progress in the pre-analytic or even the analytic, as you will see today. The progress that happened in ovarian pathology over the past 20 years is all in the post-analytic. And we as pathologists need to understand that, need to understand what the transformation that happened in ovarian pathology over the past 20 years, and it is all happening after you release the report. So I really need to understand that very well. I need to understand what my report means to the patient and to the gynecologist. Let me start by the introduction. I like to start with this picture. This is me, 1981, about 40 years ago or 35 years ago, with my friend and mentor, Dr. Amir Siddi. Dr. Amir Siddi is retired now, but he was my mentor, and he's still my mentor in everything in pathology and life. I like this picture a lot. It is hanging here in my office because it shows where I started. This is the level of the lab in Ain Shams University in 1981. This is how sophisticated we wear in our practice. The embryology of the ovary, we all know, we have the surface epithelium and the stroma and the ova. The surface epithelium is driven from the coelomic epithelium of the embryo. The coelomic epithelium covers the ovary and also forms the peritoneum. So it is important for me to know that the surface of the ovary and the peritoneum is the same. It's the same type of epithelium. Six cord, the cells of the sixth cord penetrate into the genitourinary ridge of the embryo and form the stroma of the ovary or the stroma of the testicle, the gonad. In the ovary, we recognize the theca cells and the granulosa cells, but also the stroma is fibroblast. These are the components of the sixth cord stroma of the ovary. Remember, they form also the sixth cords in the gonad, in the testicle, i.e. Sertoli cells and Leydig cells. So when tumors arise from the sixth cord stromal cells of the ovary, they can take the female differentiation, i.e. granulosa cells and theca cells, or the male differentiation, i.e. Sertoli and Leydig cells. Of course, in the middle of all of this, we have the primordial follicles, and the primordial follicle is the germ cell that will give rise to germ cell tumors. So the ovary, the complexity of the ovary comes from the fact that it is driven from three different sources: epithelium, sixth cord stromal, and primordial follicles. And therefore, the types of tumors are, as we teach in medical students, either surface epithelium, the serous, mucinous, endometrioid, clear cell, and Brenner. Germ cells, we know the teratoma, dysgerminoma, yolk sac, and choriocarcinoma. And the sixth cord stromal, the stromal are the fibroma, and the sixth cord will be granulosa, theca, and Sertoli. Let us not forget that the ovary receives a considerable amount of metastases from other organs in the abdomen, namely stomach, breast, and colon. So understanding the embryology and the classification of ovarian tumor, I think, to me at least, was very critical in keeping things in their boxes and not mixing them together, especially when I'm doing a frozen section. Let us now talk about frozen sections. And this is the downtown of Minneapolis, where we are, of course, in summer when the weather is beautiful. The philosophy of intraoperative consultation, I want to be very clear that the purpose of the frozen section is to help guide the next step in surgery. So if you think about that, then I need to understand what could be the next step in surgery, and then I will give my diagnosis to help the surgeon with their next step in surgery. That is the purpose of the frozen section. It is not time to provide a comprehensive diagnosis or to address all aspects of the case. And that is where we sometimes run into trouble. I see this among pathologists. They create the problem for themselves and then they will make the mistake. Well, why did you say this? Why did you say that? You were not asked to say this or to say that. You were asked to answer one question and one question only. The question is, what should the surgeon do now? It is time to answer the most relevant question on the surgeon's mind. And the goal is to be safe as much as possible. And when we say safe, we mean safe for the patient, not safe for ourselves. Safe for the patient, not safe for ourselves. What does that mean? I want the patient not to be harmed. I see pathologists giving frozen section. Yes, I'm trying to give the correct frozen section, but I'm trying to protect myself. I'm trying to be correct. I'm trying to be not making mistakes. If you go into the frozen section with this mentality, that is not the right mentality today. The mentality today, I don't care. I always tell the surgeons, I don't care if I'm right or I'm wrong. All I care about is that the patient at this very moment not to be harmed. And I will show you some examples of what do I really mean by that. So let us jump into a frozen section diagnosis. When the surgeon starts the surgery, they start by doing either a cystectomy or an oophorectomy. Now they ask you for a frozen section. What are the other options? What are the other options that the surgeon may do? What are the next steps? So here are the next steps. Depending on your frozen section diagnosis, they may either do an appendectomy or a bowel resection if you call the tumor mucinous. So any word mucinous that comes out of our mouth during frozen section will simply mean that the appendix is coming out, or at least they examine the bowel for tumors. Any cancer, if you say serous carcinoma, if you say mucinous carcinoma, if you say endometrioid carcinoma, anything to imply that this is a primary tumor of the ovary, they will proceed with the hysterectomy and removing the other ovary. When you say low-grade serous tumor carcinoma or high-grade serous carcinoma, they proceed with tumor debulking. Tumor debulking means they take every tumor they see in the abdomen of the patient. If you call it low-grade or high-grade serous carcinoma, they also may go for lymphadenectomy. Lymphadenectomy or staging of ovarian cancer is according to this publication, which today in North America is considered as their constitution. This is the most important paper. And if you have access to this paper, I really think you need to read it so you can understand what surgeons think, how they think. Currently, lymph nodes are only indicated in high-grade or low-grade serous carcinomas if they look enlarged. I want to point out also that not every gynecologist can do lymphadenectomy. Lymphadenectomy needs special training. So it is important to know whether your surgeon can perform lymphadenectomy or not. If your surgeon cannot perform lymphadenectomy, otherwise, if this is a regular gynecologist, then all of these diagnoses don't mean anything to them because they are not going to do the lymphadenectomy. Lymphadenectomy requires, in this country, they have to do 3 years of training in gynecologic oncology fellowship. So these are the options for the surgeon. So let us start with this example. So I was presented with this tumor here. It's a 12 centimeter, partly cystic, partly solid mass from a 73-year-old patient. Look at this tumor on the left. You got papillary excrescence. You have friable tissue here. And here is the frozen section, terrible frozen section. Histology is not supposed to be perfect in frozen section. What is it that you see here? I see sheets of cells. I see maybe necrosis. Is there any doubt in anybody's mind that this could be something benign? Do you think this is benign or malignant? So if you think this is malignant, maybe this is high power. Are you convinced that this is a malignant tumor? So what should I say here? I just say high-grade carcinoma. High-grade carcinoma. That's all they need to know. That's all they need to know. Once they hear high-grade carcinoma, this is what they will do. They will do hysterectomy, remove the other ovary, and they will do tumor debulking. Nobody asked me to say whether this is endometrioid, this is serous, this is blah, blah, blah. The more I say, the more mistakes I'm going to make, and that is not needed. They already got the answer to proceed with the next step in surgery. High-grade carcinoma, period. That's the end of that diagnosis. You know what you need to do? you need to do a hysterectomy, you need to do tumor debulking. I see some colleagues waiting in the waiting room, Dr. Rania. If you recognize our friends, let them in, please.
Okay, Dr. Mahmoud. Okay.
All right. Let's look at this tumor here. I am doing frozen section, and I received a solid mass, 3.7 centimeter, from a 58-year-old patient. What do you think this tumor is? So this is a frozen section. You are looking at this. All right, high power. You can see on the left, very monotonous cells. On the right, you can see some stromal cells. I don't know what this is. I don't see mitosis. What do you want to call this? What should I call this intraoperatively? Is there any doubt in anybody's mind now that this could be cancer? I don't think anyone would look at this and say this is cancer. So, all right, negative for malignancy. I think it's a fibroma. That's the end of that. Negative for malignancy. That's all they need to know. Once they hear negative for malignancy, what do you think they will do? They will stop. So you don't have to go down this list. You're not going, the surgeon is not going to do any of these things. Negative for malignancy, close and go home. That's all they need to know. And I want to point out the difference between the one on the left and the one on the right. Look at these pictures. The one on the left is the one we just looked now at, and we called it negative for malignancy because it looked like fibroma. What about the one on the right? The one on the right is also 6-chord tumor, but you can see round structures like rosettes. I see chords. Looks like maybe called exoner bodies. I see insular pattern. What do you think this is? I think we all will agree on frozen section that this is a granulosa cell tumor. So it is very important to make a distinction between fibroma and granulosa cell tumor, even though they both belong to the same family, the 6-chord stromal tumors. But one of them is 6-chord and the other one is stromal. It's very important to tell the difference between the two, because if you don't, if you get the fibroma on frozen section and call it 6-chord stromal tumor, what do you think the surgeon heard? The surgeon probably heard the granulosa cell. And some surgeons, like we have a surgeon here who would do lymphadenectomy for granulosa cell tumor. So 6-chord stromal tumor during intraoperative consultation, I don't like this diagnosis during intraoperative consultation, because if you tell the surgeon 6-chord stromal tumor, which one of them? Is it granulosa cell tumor? Is it Sertoli cell tumor? If you tell me granulosa or you tell me Sertoli, I'm going to take the lymph nodes out. If you tell me fibroma or thecoma, I will not. So I don't like using the term 6-chord stromal tumor. And that is one of the examples where I see pathologists trying to protect themselves. I say, you know what? I called it 6-chord stromal tumor. It's an umbrella of tumors, so I will never be wrong. Yes, of course, you will not be wrong. But the patient may end up having lymphadenectomy and live for the rest of her life with lower leg edema when she really didn't need it. So I want to be safe for the patient, not safe for myself. Just call something bizarre, something ambiguous intraoperatively to protect myself, and the patient may end up being harmed. So I try to tell my colleagues not to use the term 6-chord stromal tumor intraoperatively. If it looks like fibroma, say negative for malignancy. If it looks like granulosa cell tumor, call it granulosa cell tumor. How about this one? This is a 22-centimeter mass from a 45-year-old. Look at the left. On the left, you see the tumor, partly cystic, partly solid. You see mucus coming everywhere. You see necrosis. I think we will all agree, just grossly looking at this, that this is a mucinous tumor. Here is the microscopic on the right. You see, yes, of course, I see mucin. I see intracellular mucin and extracellular mucin. What do you think this tumor is? What do you want to call this? Intraoperatively. Again, I'm talking intraoperatively. What would this tumor be called intraoperatively? On one end of the spectrum, you have mucinous cystadenoma. Do you think this is a mucinous cystadenoma? If you call it mucinous cystadenoma, in other words, it's benign, just close and go home. I don't think anyone will think this could be just a mucinous cystadenoma. So the step after that is borderline tumor, and the step after that is mucinous carcinoma. Which one do you think it is? Do you think it is borderline, or do you think it is mucinous? Some of you now are saying, is it carcinoma? Some of you are saying borderline. Some of you are saying carcinoma. Some of you are saying, oh, I need more sections. Some of you are saying, oh, the histology is terrible. Of course, the histology is terrible. And we don't have time to do multiple sections during the frozen section. So I will only say this is at least borderline mucinous tumor. At least borderline mucinous tumor. What does that mean to the surgeon at this point? Once they heard the word mucinous, they are going to go for the appendix because this could be metastatic. They heard you say at least, so probably this is carcinoma. They don't want at the end this to be carcinoma, so they probably are going to proceed with a hysterectomy and contralateral oophorectomy. Maybe they can do some omentectomy while they are there. So don't sweat it too much. Like, don't beat yourself on frozen section and oh, I called it borderline. Is it carcinoma? Is it this? Is it that? That's not important. During the frozen section, all they need to know is that this is not mucinous cystadenoma, but they need to do something more than that because it is probably borderline or probably going to be mucinous carcinoma. What about this? So this is an omental biopsy. They go in, the patient has omental cake, 68-year-old. You see the omentum on the left, you see the cells, and on the right, you can see cells. Is there any doubt in anybody's mind now that this is cancer? Is there a chance this is not cancer? I think we will all agree that this has to be cancer. Do you think this is ovarian? Do you think this is endometrial? What do you think it is? I don't know what it is, but I know it is a high-grade carcinoma, and that's all I have to say now. This is a high-grade carcinoma. You give me an omentum with malignant cells, mitosis everywhere. I see some monobodies. I see necrosis. This is high-grade carcinoma, and it is metastatic. It is not up to me during the frozen section to say this is ovarian, this is fallopian tube, this is endometrium. None of that is important. It's omentum with malignant cells, so it is metastatic carcinoma. That's it. What about this one? This was a solid 23.5 centimeter ovarian mass from a 66-year-old. And this, when I received this, actually, as I was preparing this talk about a month ago, I received this frozen section. I said, this frozen section has to be in the talk because it is unbelievable. This mass, the surgeon, I called the mass. I said, what is going on? What is this? She gave me this bulk of ugliness, something necrotic, something. I don't know what's going on. I said, what's going on here? Is this ovarian? Is this uterine? What is this? And she said, well, it's interesting you say that because it is sitting like where the ovary should be, but I don't see the ovary, and it is actually invading into the uterus. I said, is it invading into the uterus, or do you think it is coming out of the uterus? She said, well, maybe it is coming out of the uterus. I don't know. Like, it's a mess. Okay, here's the frozen section on the right. What do you call this? Again, I think everybody on the call now will say this is cancer. Of course, this is cancer, some sort of malignancy. There is no way this could be benign, but I don't know what it is. So here's the higher power on the left. You can see cells, are they clumping together? Like, is this epithelial? Or they are fragmented. There's discohesive cells that on the left here, these cells are discohesive. These cells are cohesive. I don't know what this is. I see some globules. I see ugly nuclei. I don't know what that is. So I called her back and I said, well, this is positive for malignancy. And I don't know, it's either a high-grade carcinoma or it actually could even be a sarcoma. If this comes back as a leiomyosarcoma, I wouldn't be surprised. But it is not for me now to tell you which one it is. So she heard the diagnosis, positive for malignancy, high-grade carcinoma versus sarcoma. What did she do? She went down the list. She removed she moved the uterus, obviously. She removed the other ovary, and she did tumor debulking. She didn't do staging. The patient was not fit for lymphadenectomy. So the surgery stopped at that point. Are you curious to know what that tumor was? All right. This is what the tumor looked like. All right, so on the left here, top left, you can see areas of myxomatous change. I see microcystic spaces, high power. On the right, I see hyaline globules. Look at the hyaline globules. So I must confess, when I was doing the frozen section, Dr. Zainab is, okay. When I was doing the frozen section, I had a first-year resident with me. So the resident looked at this and looked at the hyaline globules and said, oh, this is a yolk sac tumor. I said, oh, shut up. Yolk sac tumor in a 68-year-old. I never heard about that. I never saw yolk sac tumor in an older woman. Of course, when the permanent sections came, they look like yolk sac tumor. I did SAL4 and it was positive. So guess what? I ended up calling that yolk sac tumor in a 66-year-old. I've been doing this for 40 years. And this is the first time I see yolk sac tumor in a 66-year-old patient. We learn something new every day. But the point is, this is an example of me not calling this yolk sac. I would be stupid if I called that yolk sac tumor on a frozen section in a 66-year-old. I would be out of my mind if I do that. But guess what? The patient was safe. Was I wrong thinking of sarcoma? Yes, it is not sarcoma. I thought it could be sarcoma. But the important thing is the patient received the right treatment, the right surgery. So just focus on that. We want the patient to get the right surgery. I don't care if I'm right or wrong. I care about the patient getting the right surgery. How do I get to the patient to get the right surgery? I hope I went over a lot of things. I threw a lot of things at you. I talked about knowing your gynecologist. Can they do the surgery, or that is all their limitations? I threw at you things about the appendix. I threw at you a lot of things. But the key points in intraoperative consultation, we want to be safe. So the first thing is, who is asking for the frozen section? Dr. Sarah is asking, could this be clear cell carcinoma? Of course, this could have been clear cell carcinoma. Of course, I looked at that. I did napsin A, I did cytokeratins, believe me, before I make a crazy diagnosis of yolk sac tumor, I had to make sure that I excluded clear cell carcinoma. Of course, during frozen section, I thought it could be clear cell carcinoma, but I wasn't sure. But it wasn't clear cell carcinoma. So again, the first thing is make sure you understand who is asking for the frozen section. Who is that surgeon? What can they do and what can they not do? And what is their philosophy in surgery? I never do a frozen section without looking at the specimen, because gross inspection is critical. And I read the clinical history. If I don't have time to read the clinical history, I ask the resident or the fellow to read the clinical history every day and go over the history with me. We had a case of an ovarian tumor, and that was a couple of years ago. I was doing the frozen section, and it looked like thecoma, for God's sake, just as I showed you, just fibroma. And the fellow came to me and said, well, I said, what do you know about this patient? He said, blah, 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 the patient is whatever. And he said, you know, she had gastric cancer. What? Gastric cancer? Oh, you better look for those signet ring cells. We got high power, of course, signet ring cells were there, and that was a Krukenberg tumor. So knowing clinical history and looking at the gross is very, very important. If you see any mucinous differentiation, it's important to communicate mucinous differentiation. We like to distinguish between low-grade and high-grade serous carcinoma. Why is that? Low-grade serous carcinoma does not respond to chemotherapy. So the operation is the only hope the patient has. So when we tell them low-grade serous carcinoma, they try to debulk everything. They try to remove everything, because the patient has to get rid of her tumor now. If you call it high-grade serous tumor, high-grade serous tumors do very well with chemotherapy. So they may not remove all the tumor, and they may leave a little bit behind. So distinguishing between low-grade and high-grade serous tumor is very important for the patient intraoperatively. Please don't use the word sex-cord stromal tumor during frozen section, because if they think you said granulosa or Sertoli, they will remove the lymph nodes unnecessarily. The one thing, we wrote a paper about this. Can pathologists distinguish between primary and metastatic tumors? Can you distinguish between primary and metastatic tumor in any of the tumors I showed you before? We did an audit of our university back at the University of Toronto, and we found that pathologists are 50-50 chance getting it right. So it's almost like flipping a coin, malik wala ktaba. You just can't. No matter how confident you think you are, you just cannot tell. So don't volunteer. So like that case of high-grade serous carcinoma, because if you say serous carcinoma, that by definition is a primary tumor. That case of signet ring carcinoma, if the patient had gastric cancer, if you are sure 100% certain that this is metastatic, yes, you can say this is metastatic tumor. But otherwise, don't volunteer this is primary or metastatic. That is my part about the frozen section. Let us move more into a little bit update, as if I'm signing out with you and we just go over some cases. This is the view again of the downtown Minneapolis as we moved from summer to El Kharif. For fall, you can see the colors of the leaves start to change, and obviously we are pathologists. We like patterns, we like colors. So this picture, I like it very much because of the different colors. All right, let us talk about tubal neoplastic neoplasms and the spectrum. Of course, everybody's talking about this, and you have 3 steps: P53 signature, or tubal intraepithelial lesion in transition or tilt, serous tubal in situ carcinoma, or stick. I am sure that you are diagnosing sticks now in your cases, and maybe some tilt. Is it important to distinguish tilt from stick? Honestly, I don't think it is important. But I think it is important. If you see a stick, you have to call it. And these are the criteria. This presentation has many tables. I leave tables for you, and you can take a screenshot of some of these tables if you think they are useful. Send me an email if you are interested in any of these tables, and I will send them to you. But this is how we sort out any abnormality in the fallopian tube. So I think this is an easy case. If this is the normal epithelium of the fallopian tube of the fimbrial end, it is normal because you have two cell types. You have the secretory and the non-secretory types, and you have cilia. So once you have two cell types and you have cilia, then this is normal. If you come down here, you start going on the left, you can see here they started to pile up. It's a single type, not two types, and they lost the cilia. So I think this area here is good for stick. Again, coming down here, this is stick. You have nuclear atypia, you have piling up. This is stick. Do you have to do P53? Here's another field. You can see mitosis. You can see stratification. This is stick. Do you have to do P53? You don't have to. Well, I am a minimalist. I don't like doing stains unnecessarily. I don't like billing the patient. I don't like billing insurance. I think I can recognize this as a stick, and I don't need to do P53. What happens after that? What happens after stick, after neoplasia of the fimbrial end epithelium? Here is the next step. So here, if you look at on the right here, I think this is stick. And you can see on the left, as we progress to the left, you can see it started to become really serous carcinoma. And this area here on the far left, on high power, I think we will all agree that this is serous carcinoma. So the purpose here is just to show you the progression from stick to invasive serous carcinoma. Why is this important? Recognizing that this entity is important because now we have to follow a certain protocol cutting the fallopian tubes. It's called the protocol for sectioning of extensively examining the fimbrial end, or CFIM for short. I don't know if you use the CFIM protocol in your department. I hope you do. Text me in this chat if you are doing it or not. It is important to cut the fallopian tube according to this protocol. Why is it important? Because the argument is, listen, the patient had the fallopian tube out and you find stick. Well, the stick is out. Why do you need to report it? Why do you need to say that she has a stick? Yes, I need to report it because this patient may be, it could be a marker for BRCA mutation. And patients with tubal metaplasia are at high risk of developing peritoneal and contralateral high-grade serous carcinoma. So if you see a stick in any fallopian tube, even if the fallopian tube was removed with the uterus for prolapse or for fibroid or whatever the reason, and you see a stick, it's important to report stick in your case because this patient is going to be at risk for developing peritoneal carcinoma or high-grade serous carcinoma on the other side. Again, I don't know if patients in Egypt are tested for BRCA mutation, but obviously a patient with a stick diagnosis should be tested for BRCA mutation. And of course, once we see stick, now this opens the door for the diagnosis of tubo-ovarian carcinoma in the final diagnosis. I will explain what I mean by that, but I want to share with you a report. So this is one of my report. Again, as I was preparing for this talk, I thought maybe I should just show you a final diagnosis on a case like that. So this case came in 5 parts. The first part was an omentectomy, and it was positive for high-grade carcinoma, consistent with metastatic high-grade serous carcinoma. That is the one-line diagnosis. The left salpingo-oophorectomy, the ovary had high-grade serous carcinoma. I'm not saying, remember, I'm not saying that this is an ovarian serous carcinoma. There's a big difference here. I'm saying that the ovary has high-grade serous carcinoma because I don't know where that carcinoma came from. Well, we will know where that carcinoma came from in a second. But look at the fallopian tube. The fallopian tube on the left had no significant histologic abnormality. Now they did the hysterectomy with the right salpingo-oophorectomy. Look at the right ovary. Now the right ovary also has high-grade serous carcinoma, and the right fallopian tube had stick and had serous carcinoma. So where do you think this tumor started? This tumor started on the right fallopian tube, invaded the fallopian tube, invaded the ovary on this side, metastasized to the ovary on the other side, and metastasized to the omentum. Bladder peritoneum is positive. The pericolic gutter peritoneum is positive. So this is a stage 3 high-grade serous carcinoma, straightforward, that we see every day. If the tumor is only here in the pelvis, it's going to be stage 2. Once it crosses the pelvis and goes into the omentum, it is stage 3. We didn't say this is a primary this or a primary that. You see how now, according to the CAP checklist, we are just enumerating the organs that are involved. So here are the organs. This is the CAP checklist. This is the most, the current version of the CAP checklist. And these are your options. And you can see here that there are options to call it tubo-ovarian carcinoma. How do you work this list here? CAP provided us with this table to assign the primary site for high-grade serous carcinoma. I'm sure you read that table, but I want to go over that table, spend a couple of minutes to talk about it a little bit. The tumor is, the carcinoma is considered a primary fallopian tube carcinoma if you have stick, if the mucosa of the fallopian tube is involved with or without stick, if part or entire length of the fallopian tube is inseparable from the tubo-ovarian mass. Think about that a little bit. With every high-grade serous carcinoma you get, look at the tumor and look at the fallopian tube. If the fallopian tube is stuck on the tumor, then that is considered as primary fallopian tube carcinoma. Of course, it will be stage 2. The tumor is considered as primary ovarian if the fallopian tube is separate from the mass and if that fallopian tube did not have stick or high-grade serous carcinoma. When was the last time you saw that? I don't know. But here you go. If the fallopian tube and the ovary are not available for you to examine them, and the pathologic findings are consistent with extrauterine, i.e. it's not primary endometrial serous carcinoma, then you can call it tubo-ovarian and don't worry about whether it is ovarian or tuber. Of course, if none of that is available, then it is peritoneal. Then the question to you now is it important? Why is it important to decide whether it is fallopian tube or ovary? I really think it's not important. And I think we run in trouble when we think that we have to make the declaration as to whether this is one thing or the other. No, CAP checklist, as I showed you my report now, the College of American Pathologists, CAP, doesn't require us really it really doesn't make a difference one way or another, because staging is the same. Staging of these tumors is the same. They are staged the same. I want to say a couple of words about serous carcinomas and the difference between low-grade and high-grade serous carcinomas. Here are some, of course, the morphology obviously is your number one criterion, but here are some stains that can help you distinguishing between the two. And the whole idea is that molecularly, these are two different tumors. High-grade serous tumors are based on P53, where low-grade serous tumors are, it's a KRAS mutation or BRAF mutation. So these are two different tumors. And making the distinction between the two is very important, as I said before, because high-grade serous tumors respond to chemotherapy, low-grade serous tumors do not respond to chemotherapy. So you need to tell your report, don't go ambiguous on serous tumors. You have to commit yourself to either it is low-grade or high-grade, because that dictates whether the patient is going to get chemotherapy or not. And P53 is useful. I use P53 in this regard when there is debate. And I listed here the patterns of P53 abnormality. And I don't know if you use these patterns or not. We all know that P53 is considered abnormal if it is diffuse and strongly positive. But if it is completely negative, that also is abnormal. It's called the null pattern. I'm sure you know that. So if you have some cells positive and some cells are negative, that will be wild P53, and that is the normal P53. Some of us don't know that if you see cytoplasmic staining of P53, that is also abnormal. So if you see any of these three patterns, then probably you are dealing with high-grade serous carcinoma. Again, I emphasize your oncologist really wants to know if it is high-grade or low-grade, because they want to know if the patient is going to respond or not. Even if they give this patient chemotherapy, they know that she is not going to respond to chemotherapy. Let us say a few words about serous borderline tumors. I think if I showed this picture to any one of you, you will not have a problem at all calling it a borderline. This is serous, and then it comes here, it starts to pile up a little bit. It has finger-like projections, detached cell clusters. Cells are atypical. On high power, you can see atypia, you can see mitosis. I think we all agree on this being borderline serous tumor. Borderline serous tumor is an important diagnosis because this tumor typically is seen in younger patients, and patients, once they get the diagnosis, typically what happens is that this patient had an ovarian cyst and she is young, so the gynecologist goes there and does just a cystectomy to preserve the patient's fertility and sends it to you, and then you send them back the report as borderline serous tumor. What does that mean for the patient? It's a big deal, because borderline serous tumor means that they need to go back and now remove this complete ovary, and they have to do a contralateral oophorectomy. So overnight, a 35-year-old patient became menopausal, and that obviously is a serious diagnosis. So the consequences of a borderline serous tumor is typically complete oophorectomy, bilateral oophorectomy, and sometimes even hysterectomy. So as I'm doing my job, looking at slides, it looks like borderline. We all agree that this is borderline. And all of a sudden, I run into an area that looks like this. Look what happened here. All of a sudden, cells started to become plump and started to be large. Look what happened. They have prominent nucleoli, but the NC ratio is low. So you have cells here with lower NC ratio, plump cells, pink with prominent nucleoli. That is a criterion for invasion. So now we moved from just borderline tumor to a borderline tumor with micro-invasive carcinoma. This is one pattern of micro-invasion. The other pattern is here, where you have papillary structures with a space around them. So even though you don't see desmoplastic reaction in any of these pictures, this is microinvasive serous carcinoma. If it is less than 5 millimeters, if this is more than 5 millimeters, then it is a low-grade serous carcinoma. This is a very serious diagnosis. This is a very serious diagnosis because now, if they removed this as an ovarian cyst and you found borderline tumor, go back and submit more sections because you really want to find invasion. And you find invasion by these two criteria: plump cells with pink cytoplasm, prominent nucleoli, or papillary structures with a space around them. Then now your diagnosis is going to be borderline serous tumor with microinvasion. I guarantee you that the surgeon is going to go back and maybe start to do staging procedure, maybe some omentectomy, peritoneal biopsy. If they know how to do lymphadenectomy, they may even do lymphadenectomy. So again, this is a young patient who went from having a simple ovarian cyst to almost cancer staging. Few words about mucinous tumors and the mucinous continuum of neoplasia. I think the one on the far left, you can all agree that this is a borderline tumor. Again, it is mucinous for obvious reasons, and it is borderline because of the stratification and everything. And you get more sections, and once you start to have cells that pile up like finger-like projections without stroma in them, so that is good for the diagnosis of intraepithelial carcinoma. Once you have cribriform pattern and confluent growth, then that would be mucinous carcinoma, the expansile subtype. So this is the continuum of morphology, and every time you get a tumor and you call it borderline tumor, we go back and get more sections because we want to diagnose intraepithelial carcinoma or mucinous carcinoma expansile type. Again, because that probably will mean that the surgeon will go back and stage this patient. This is an important paper. Again, gynecologists today use it here in North America as their constitution. It shows the difference between mucinous tumors, and it reminds us that mucinous tumors are a function of KRAS mutation. HER2 and P53 are secondary events, and they are just secondary mutations, but the primary mutation in mucinous tumors are KRAS mutation. The key for diagnosis is back-to-back architecture and complex architecture. Is it important to separate expansile from infiltrative? Absolutely, absolutely. Because of the treatment, and again, according to this, which is every gynecologist here in North America follows, if it's an early stage tumor, the two tumors are managed differently if you call it expansile or if you call it infiltrative. Honestly, I struggle with this, which one is infiltrative and which one is expansile. And the time that I forget to say one or the other, they will call me. They will say, you called it mucinous carcinoma, but you didn't say infiltrative or expansile. So my golden rule now is that I only call it infiltrative if I see individual cells. As long as you see glands and you see cribriform pattern, call it expansile, especially if the patient is young. But if you see individual cells, you can call it infiltrative. I want to move out of the epithelial tumors into the next category, which is 6-chord stromal tumors. And this is the WHO classification, again, showing the pure stromal on the left, fibroma, thecoma, and the pure 6-chord in the middle, granulosa cells, if the differentiation is female, or Sertoli if the differentiation is male, or the sketat or the 6-chord stromal tumor with annular tubules. I don't know if you have encountered this entity, luteinizing thecoma, in patients, young patients with sclerosing peritonitis. About every year or so, we get one of those cases. It's a very sad disease because it's fatal, and the whole abdomen is fibrotic. And what you get is as an ovarian tumor, and it looks like sarcoma, but it is so luteinized. So if you get that, call your gynecologist to make sure that the patient doesn't have sclerosing peritonitis, because that could be the first sign that she has sclerosing peritonitis. So the difference between these two is the management. If you make any of these diagnoses on the left, salpingo or oophorectomy is the only treatment needed. But once you cross that line and you make any of the diagnoses on the right, then it is a lot more than salpingo or oophorectomy. It's hysterectomy, it's omentectomy, it's peritoneal sampling, and as I said, some gynecologists will even do lymphadenectomy. It's a very serious diagnosis. So it is very important to distinguish between these two. And the morphology is supposed to be simple, but nothing in life is simple. And when you study these tumors first, you think that, of course, I can tell the difference between them. No, you can't, because there are many gray areas. And the one stain that I found useful is reticulin stain, because reticulin in fibromas and stroma surround individual cells, but in six-core tumors, they surround groups of cells, as in this granulosa cell. So I hope your lab can do reticulin. Not every lab does reticulin, I know that. Some reticulin is terrible. But if you can perform reticulin, it will be helpful to distinguish between stromal tumors and six-core tumors. There is a group called steroid cell tumors sitting in this category, and they are four. I highlighted them for you. They are all positive for inhibin, calretinin, Milan A, CD99, SF1. All of that is useless. It doesn't really help me. What really helps me is the morphology. And the difference between stromal luteoma and Leydig cell tumor is that Leydig cell tumors start in the hilum, and stromal tumors are, stromal luteoma is in the stroma of the ovary. So if you have the tumor limited to the hilum of the ovary, most likely it is a Leydig cell tumor. These are usually androgenic. They will tell you the patient is struggling with hirsutism and deepening of voice and everything. The one tumor that I need to separate from these tumors is the one known as steroid tumor. These are typically vacuolated cells. It could be androgenic or could secrete steroids, cortisone. And because this is the only one that can become malignant in this category. And here are the criteria of malignancy. So if your tumor looks like this, this is a simple diagnosis, especially if it is in the hilum, a couple of centimeters, high power, round nuclei, monotonous, prominent nucleoli, pink cytoplasm, low NC ratio, then probably we are dealing with, Leydig cell tumor. We are dealing with this because cells are monotonous and cells are, they have pink cytoplasm. Typically it's lobulated, as you can see here. Of course, we will see adult granulosa cell tumors. The picture, the gross picture on the left is important because every granulosa cell tumor looks like this. I can spot a granulosa cell tumor from the other side of the room because the tumor is relatively large and it is typically necrotic and it looks very, very scary. Microscopy, you have the cold excimer bodies, you have the insular bodies, and of course on high power you can see the nuclear grooves. Granulosa cell tumor is an important tumor because it belongs to the malignant category, even though really nothing looks malignant about it, except for the fact that they typically recur. There is no patient with granulosa cell tumor that did not recur. They may recur after 5 years, they may recur after 30 years, they may recur after 37 years, which is the record, but eventually they will recur. And when they do recur, they recur in the pelvis and retroperitoneum around the bowel. So the diagnosis is very important because it tells the gynecologist a lot about what to do to this patient. This patient is not going to respond to any chemotherapy, and this patient is going to recur, so they better keep an eye on her with regular follow-up. One type of granulosa cell tumor, and I don't know if you have seen this before, but one type of granulosa cell tumor may have some cells in the middle that look like hepatocytes, and they sure stain like hepatocytes. So that's a special type of granulosa cell tumor that is called granulosa cell tumor with hepatocytic differentiation, has absolutely no clinical relevance. If you missed it, it doesn't matter. It has no clinical relevance. A couple of words about Sertoli-Leydig tumors. You have a tumor that looks very blue, very cellular, like the picture here. You get high power. You start to see some cords, but I don't know what this is. What am I going to call this? This is not granulosa cell tumor because we don't have round structures, but is it thecoma? I don't know what it is. I have to keep looking until I must see tubules. If you don't see tubules in your tumor, submit more sections, submit more sections. You keep submitting more sections until you find convincing tubules. Without convincing tubules, you cannot call it Sertoli-Leydig tumor. And of course, for most Sertoli-Leydig tumors, you are going to have Leydig cells, obviously, in the middle. Look at this tumor here on the left. Is that easy to call it Sertoli-Leydig or not? I don't know if it is easy. I know it is 6-core. Is it granulosa cell? I don't know. I don't see cold external bodies, and I see Leydig cells. And the surgeon tells me the patient has hirsutism. Maybe that helps me. And if I find heterologous components, if I find colonic mucosa, that obviously is a very good diagnostic feature for Sertoli-Leydig tumors. So as far as the update is concerned, if you are not familiar with the molecular classification of Sertoli-Leydig tumor, I think this is really, really, really very important, that there are 3 types of Sertoli-Leydig tumors. The one, like the one I just showed you, this patient was 27 years old. It was grade 3, as you could see. It was poorly differentiated, and it has heterologous component. So the problem here is that once you make that diagnosis of grade 3 Sertoli-Leydig tumor with heterologous component, the oncologist should think of DICER1 mutation. This patient should be tested, because if she turns out to be, this patient actually was mutant, and she was only diagnosed because of her Sertoli tumor. As you know, DICER1 mutant patients are susceptible for many, many other malignancies. The second category is the FOXL2 mutation. This is what you see in postmenopausal tumors, and it is usually estrogenic, but it has no heterologous components. And then probably the one you most commonly see are the ones that are wild type. They have no germline mutations, and they are the intermediate or the grade 1 Sertoli-Leydig tumors, and these are completely normal. An update about the immunohistochemistry of of 6-core stromal tumors. I listed some stains because people like to do immune stains. I don't know why, but obviously people like to do stains, so I have to summarize the stains for you. And as you can see, I hope this table shows you that there is no stain that distinguishes between Sertoli-Leydig and granulosa cell tumor. If you cannot figure out whether it is Sertoli-Leydig or granulosa cell tumor by histology, then nothing can help you. Clinical picture could help you. Histology obviously is the most important thing, but there is no stain that can distinguish between the two. Those stains are listed here just to help you distinguish them from the carcinoma. If you think it is carcinoma, just do cytokeratin. So the typical stain is cytokeratin and inhibin. If it is positive inhibin, negative cytokeratin, then it is 6-course Truman. If it is the opposite, then it is the opposite. I hope I made the point here about the use of immunohistochemistry in 6-course stromal tumors, and I made the point about the clinical connotation in terms of germline mutations in sertoli Leydig tumors. You all have seen this before. This is the general scheme of the last category of ovarian tumors, germ cell tumors. I'm not going to spend time on germ cell tumors. They need a talk by themselves. But I want to summarize the immunostaining for them. Again, if you like immunostains, and immunostains in germ cell tumors are important because you want to rule out other components if the tumor appears to be mixed. CD117 is positive in dysgerminoma, negative in the rest. CD30, I like it because it highlights any embryonal carcinoma. Beta HCG and inhibin are positive in choreo and negative in the rest. And SAL4, as I showed you, that magical case is positive in yolk sac tumor. So if you want to have a battery of germ cell tumors, so this is the battery: CD117, CD30, beta HCG, inhibin, and SAL4. The rest, OCT3, 4, SOX2, glypican, AFP, are soft because they don't work every time. Alpha-fetoprotein, I hate that stain because it never works. If it works for you, it's good on you, but I never rely on alpha-fetoprotein. I went over time a little bit, and I apologize for that. But in closing, I want to say a few words. I hope I could show you that ovarian pathology has become one of the most clinically driven fields in gynecologic pathology. It is all about what happens to the patient. It is all about how gynecologists interpret our diagnosis, and it is all about the post-analytic phase. We failed to improve our services in the pre-analytic. If you want to talk about cervical cancer, all the development happened in the pre-analytic. Pap smears, HPV testing, name it. So we did a lot of achievement pre-analytic in cervix. You want to talk about analytic? Yes, molecular profiling of endometrial cancer. Endometrial cancer is a field where the analytic development helped the patient a lot. But in ovarian cancer, unfortunately, we failed to find screening tests. We don't have much to offer in terms of analysis. What is the most magical thing I said today? High grade or low grade? Good deal. Like it's not rocket science. What really matters is what happens to the patient after the clinician reads your report. I hope I emphasized that for you today. The post-analytic phase in our test, what happens to the patient after you release your report, is the focus of your practice in ovarian cancer. It is therefore extremely important. It's extremely important to develop a strong bond with your gynecologist. Our gynecologists here are on speed dial. We text each other all the time. I have their children's pictures on my iPhone. We text them for their birthdays. They follow me everywhere I go because we are a team. Like you work with your gynecologist like you work with members of your own family, because it is very important to understand how your gynecologists think and what do they plan, how they plan to use your report. Finally, this is the central office for our university. Again, I chose a summer day to take this picture, and thank you very much for your attendance. And if you have any questions, please post them in the chat.